And as we know, this is welcome to our Saturday session. And today's topic is the famous the sneak peek at pulmonary embolism. It's a very, very common, but very kind of a fatal topic. It always is on the uh, big letters in our differential diagnosis here. So our presenter today is Dr. Poornema Ramasamy. So she's not only an MD, but she is also an MBA, which is like she's got her degree with business administration. And she's a specialist in hospital medicine and wound care with Prisma Health in Richland, Columbia, South Carolina. South Carolina is one of the eastern states up here. She belongs to the 1993 KMC batch, did her internal medicine residency with Prisma Health, and continued as a hospitalist there. And then she also took her time to do the MBA, bless your heart, at the USC Darla Moore School of Business. And she, oh yeah, good. She aspires to have a startup with healthcare in India, and she specializes in wound care, as I said. So there will be a lot of help there. And she serves on the antibiotic stewardship committee in the hospital. And I know from personally interacting with her, she is involved in a lot of welfare projects, activist projects, child activist programs, gun control. So she's an activist. So if anyone wants to have something like a voluntary thing, here you go. She is there to help out to you guys, always willing to help and always full of ideas and help. So here we go, Dr. Poornema. Over to you.
All right. Good greetings, everyone. It's good morning, good evening, depending upon where you are. So thank you, Maitli, for the nice introduction. So this topic is, I feel that it's important in this era because we are in 2020. Not only 2020 means 2020, it's also COVID. So there is increased risk of thromboembolism in general population, like no other times. So it's important that we refresh our memory about this. Oh, okay, what happened here? Why does this happen? Okay. So why PE? Because the diagnosis is not straightforward. I'm having a hard time suddenly with my computer. It doesn't usually happen. It happens only during Zoom times. Sorry, guys. Bear with me for a second. Okay, so I lost my, hold on okay, there we go. I lost my mouse for a second. So why PE? As I said, we are living in the COVID era, and it's not straightforward diagnosis-wise. And I'm going to tell you a story as to why I say that. And when I put this slide out, failure is a stepping stone of success, you must know by now that I'm going to share a story of my failure. So I was in residency as a second-year resident doing my ER rotation, emergency room rotation. And a lady who has history of dementia, who doesn't speak, pretty much bedbound normally, 77-year-old, comes to the emergency room. And evaluation reveals like bilateral pitting pedal edema. She had bilateral pleural effusions on X-ray, maybe some hypoxia, like 95% or 94% on room air. So we thought we did a great evaluation. I came to a conclusion that it's a new CHF onset. She was not dyspneic at all. Vital signs were otherwise stable. The presenting complaint was she's a little bit more lethargic than normal. That was it. Um, so I called the attending physician of that service and said like, hey, I got an admission for you, blah, blah, right? So he comes a couple of hours later to me, giving a look. I'll never forget that look, saying, hey, Poornema, that patient had PE. I was like, oh my God, like, how did I miss that? So, from that onwards, it happened like 13, 14 years ago. I'll never forget that. This is an unusual presentation, pleural effusion, but it's, of course, you can have it. So unless you remember or have it in your differential, you are not going to look for it. So that's why I said that. So when I'm sharing a failure story, I want to also share a success story. So after a few years, I joined as a hospitalist, rounding in a stroke floor. Patient is thin, like 50, 60-year-old, history of hypertension and stroke with one-sided weakness. I forget which side. He was bedbound, and in US, basically we don't discharge a patient if they are in the hospital and they don't have a safe discharge plan, meaning like if there's nobody in the house to take care of them, they just stay in the hospital until they get better, or we find a place in nursing home. So this patient was there in the hospital for a while. For some procedure, we had to hold Lovinox, which was a prophylaxis, though he was getting enoxaparin as a DVT prophylaxis. And it was held for a few days. This guy, I take over the service. I notice in the vital signs, there are like temperatures like 99.5, 99.7, 100 at the most. I just couldn't find out why he would have that. And I did a urine analysis, I did chest x-ray, he didn't have any complaints. His legs were looking thin, no evidence of edema. So I did a DVT study, and voila, like he was positive. And then a CT angio was done, because I kept asking him, like, do you have pain anywhere? He's like, oh, maybe in my right side when I take a deep breath. It was like after asking him several times. So it was not even a great, question, complaint. Then he had a PE. So that was another thing that, those two instances I'll never forget these two cases in my life. So it is very difficult to diagnose. High mortality. The data says that it's anywhere from 4 to 13%. It's not just in US, it's even in India. I came across a paper. It said the mortality rate is about 13%. So it has high mortality. But if you treat, the mortality rate goes significantly low. So treatment, we have made a lot of progress. We can do this treatment in the street now, like we don't even have to admit. So we have made remarkable progress in diagnosing and treatment. So so these are most often preventable mortalities. And we are in COVID-19 era. So definition of PE refers to obstruction of the pulmonary artery or one of its branches by material. Example, thrombus, tumor, or air or fat that originated elsewhere in the body. For practical purposes, we are going to stick with thrombus here today. Classification. It can be classified based on temporal pattern of presentation. So acute, subacute, or chronic, depending upon the symptoms and signs of presentation. So if the symptoms arise immediately after obstruction, that's acute. Subacute may come up within days or weeks after the event. And chronic is slowly developing over a period of months and years, and they end up with pulmonary hypertension. And we are not going to go there. It's a totally different topic. So we're going to focus on the acute and subacute PE today. Based on hemodynamic stability, so whether they are hemodynamically stable or unstable. Unstable meaning, what are the signs of hemodynamic instability? Systolic blood pressure less than 90, or a drop in systolic blood pressure greater than or equal to 40 mmHg from baseline for greater than 15 minutes. Unexplained hypotension, if you cannot if there is no sepsis, no heart failure, and MI, hypovolemia, dehydration. If you don't have any of those causes and you still see a patient with hypotension and elevated jugular venous pressure, then you are concerned about a PE unstable. And when I'm talking about PE, it doesn't have to be a large saddle embolus and like making a massive PE going and obstructing both main pulmonary arteries. Sometimes people who have like cardiovascular diseases who have poor lung and cardiovascular reserve in general, like if the EF is like 35%, 20%. Even a small embolus can cause hemodynamic instability. So hemodynamic unstable meaning may not be always massive PE. So submassive, hemodynamically stable can be submassive or intermediate risk if there is associated right ventricular strain, and low risk PE if there is no risk, no right ventricular strain. Why is it important to distinguish? Because if you are dealing with an unstable PE, the death within first 2 hours is very high, and the risk remains elevated up to 72 hours after presentation. So it is important to distinguish these two. Based on anatomic location, saddle embolus, where it acts like it is lodged at the branching of the two pulmonary arteries and act as a saddle. So that's a saddle embolus. And clot in transit, which is it's actually traveling in the process of traveling in from the heart to the lung, and lobar, segmental, and subsegmental, where they are like lodged in the peripheries. So saddle embolus, it sounds very fancy and scary, but only 22% are hemodynamically unstable. It has like 5% mortality, whereas clot in transit has 40% mortality. So we may think that saddle is more dangerous, but it's not. Lobar, and they will present as pleuritis or pulmonary infarction. Usually, they may not have hypoxia. So pathogenesis, we have to go back to our basics, virtuous triad. All the 3 steps are present: hypercoagulable state, endothelial injury, and venous stasis. All these 3 factors, if they are present, 1 or 2, or all the 3, then there is a risk of developing thromboembolism. So endothelial injury meaning trauma, surgery, like COVID this time. COVID does mess up with all the 3. Hypercoagulable state, estrogen therapy, pregnancy, obesity. Obesity is actually, they are categorizing under venous stasis, but it also causes increased, hypercoagulability. Cancer, venous stasis, as mentioned here, immobility, heart failure, obesity, pregnancy, tumor, etc. Risk factors, I'm not going to go into the detail of this, the risk factors that could be inherited and acquired. The acquired, we need to remember a few things: surgery, pregnancy, immobilization, oral contraceptives, hormonal replacement therapy, obesity. That is we are all like, we are in not only in pandemic of COVID-19, we are also dealing with obesity epidemic across the globe. Not only in the Western population, we are dealing with obesity in Indian population too. And we are talking about BMI greater than or equal to 30. And that's Dr. Varalakshmi spoke nicely about that. So that is we should not forget that. And I'm going to revisit that again later when I'm going to talk about COVID. Old age. So epidemiology, the incidence has increased because of the better diagnostic tools. We have the availability of D-dimer and CTPA has revolutionized the diagnosis of PE after late 1990s. It used to be somewhere in 80s and 90s, 70s, the incidence per 100,000 now increased to 112 cases per 100,000 after 1998. This is based in this is a study based in US. Men have more risk factors to develop PE. It increases with age, and as they age, women have higher risk of developing PE. Overall, mortality appears to be high, as I mentioned earlier. For us here, African Americans have higher percentage of mortality rate than whites, and whites in turn have higher percentage of dying when compared to American Indians and Asians, etc. But I came across a study. This was European Journal of Vascular and Endovascular Surgery, published in April 2009. And according to that, they said it is no more, Indian population is no more at lower risk of having PE. They said that mortality is still as high as 13%, like compared to the other population. Incidence was 17 per 10,000 admissions. Malignancy was the most important cause, 31%, but which is closer to it is post-op status. And when talking about post-op status, they mentioned about just general surgeries being the most common, like high risk procedures, like they had the highest incidence. And it is encouraging that we have started using in India prophylaxis enoxaparin. Okay, I have to put Ryan Gosling. I like him, so I found this, so I had to put it. Signs and symptoms. So symptoms, as I said, high index of suspicion is key. I've seen several times that the diagnosis is still missed in the ER. I've seen people not going through the Wells criteria and for pretest probability for PE. When they come with chest pain, a lot of times they call us for rule out myocardial infarction and admit for, angina types complaints. So very, very important. You have to have high index of suspicion all the time. So dyspnea at rest with exertion. It's a rapid onset. Onset is within minutes. That's the most presenting complaint. Then pain, pleuritic pain, then cough, orthopnea. Then they may have, like if they had DVT, then they may complain with just cough and calf or thigh pain. I may not have any chest symptoms at all. Wheezing, hemoptysis. There was one study that reported syncope as presenting complaint, and those who presented with syncope also had higher mortality. So it's about like 10% of the time they can have atrial fibrillation, syncope type symptoms. Those are all bad prognostic indicators. Hoarseness from a dilated pulmonary artery. I just thought it is cool to have a syndrome name here, Ortner syndrome. Signs, tachypnea. Of course, they are having trouble breathing, so they will be tachypnic. So that's the highest, most presenting sign. They may have cough, swelling, edema, tenderness, tachycardia. About 25% of the time, sinus tachycardia, unexplained, ended up having PE in the ER. Rails, decreased breath sounds. I don't know. I'm not very fond of this accentuated pulmonic component of second heart sound. It sounds very cool, but it's okay. Yeah, I'm not going to go look for it. Jugular venous distension, fever, as I said, like low grade temperature, unexplained, that can be a sign. Signs of sudden cardiac arrest, about 8%. Signs of acute acute right ventricular failure, like, elevated jugular venous pressure, heaving the right side, right S3, and so forth. Then shock or hypotension. Then sudden, like any arrhythmias, narrow complex to broad complex tachycardia, PEA, that is in an arrest. Even you have a PEA, if you guys are familiar with the ACLS protocol, PE is one of the 5 H's and 5 T's. For differential of P. And I have seen one, it was a young guy, very obese, like he was like 400 pounds, ICU, hypotension, refractory. He was on anticoagulation. We had not started thrombolysis yet. And he arrested with a PEA. We couldn't resuscitate him. He died. So lastly, hypotension and otherwise unexplained. Diagnosis. So diagnosis, we want to see CBC, serum chemistries. You may have elevated white count. Creatinine, you want to check creatinine to make sure you can do a CT angio, because you want to have a normal renal function if you are going to give them iodinated contrast. ABG, you may have in hypoxemia a lot of times, 74% of the time, widened alveolar atrial AA gradient that can be present, respiratory alkalosis, hypocapnia. Hypercapnia and lactic acidosis are uncommon, but it can happen with respiratory arrest. So abnormal oxygenation is also a bad prognostic indicator. BNP, brain natriuretic peptide, which is an indicator for heart failure and heart strain. Again, it's not a diagnostic indicator, it's a prognostic. Troponin, elevated troponin, again, is a prognostic indicator. D-dimer, we have to go in depth about D-dimer, and that aids with diagnosis when we have the probability testing done, and in case of low and intermediate probability of PE. Okay, I'm going to ask somebody to tell me what this is. I have to first find where you guys are. Is anybody interested in telling me what this is?
We're not able to see anything, Poornema.
Everything is paused. Okay, why? Okay, now can you see it?
Yes, I can. I'm not sure about the rest.
Okay. All right. So this is my computer. Okay. So this is S1Q3T3 pattern. This is like fancy. When I heard this for the first time, I was in, of course, we learned it in medical school. I had forgotten. But in residency, one of my seniors, she's like, look at this, S1Q3T3. I'm like, where is it? I'm like looking here and there. So it's something that we will not see in our life, but if you saw it, you'll never forget. This is a classic sign. It's indicative of acute cor pulmonale. So if you see S1 in lead 1 and Q3, Q and T wave inversions in lead 3, it's a sign for PE. And of course, it's not specific, but when you see this and you don't have any other explanation for patients presenting complaints, then you have to go and do a diagnostic testing for PE. So EKG or ECG abnormalities, usually it's non-specific. most commonly, 70% of the time. When I said that S1Q3 3T3, it's very fancy. You may have that or right bundle branch block, atrial arrhythmias. Those kind of things are rare, but you can see those. So the ones that have poor prognosis with the diagnosis of PE or atrial fibrillation, bradycardia, tachycardia, right bundle branch block, inferior QRF, anterior STT segment changes, and S1Q3 T3 pattern. Chest X-ray is not a good diagnostic tool. It's usually not necessary if you are going to plan to have a CT angio. It's usually done to rule out any other causes, like if you're looking for pneumonia and or pleural effusion, for any other causes for the hypoxia. So Hampton hump sign. If you find that, then yeah, you have to suspect PE. That's a wedge-shaped in the lateral segment. You can see as the arrow points out in this picture. If you see that, it's called Hampton's hump, and it is suggestive of pulmonary embolism. And it, okay. So D-dimer. So D-dimer, when you combine it with modified Wells rule, there was a study that showed that when you combine it with that, it had a pool sensitivity of 99.7% and a pool specificity of 10.8%. So it's a terrible diagnostic tool by itself. Like, you cannot rely on it. There are lots of false positive, but when you combine it, it's a highly sensitive test. So negative predictive value is high, right? Like meaning like if it is negative, then and you have low probability, then you can safely rule out PE. But can you rule in PE just with a D-dimer? No, you have to rely on the clinical tools. And we're going to look at the Wells rule in a second. So this is an expression I just learned when I was doing these slides. Let me sing you the song of my people. That means that you are going to be loud and cause this, cause some sort of disruption in peace. I just threw it out here because, when you're talking about DVT, a lot of times femoral vein, which is here, it's asterisk. In the asterisks, it's named as superficial femoral vein, and this is not a superficial vein. It is part of the deep vein family. So Wells criteria, coming to the Wells criteria and modified Wells criteria. I don't know, I've never used modified Wells criteria. I think everybody, even up to date, where I gathered a lot of information from, is supporting the traditional clinical probability assessment, which is high, moderate, and low. And all their algorithms are based on that. So, so these are the criteria we recommend, and it's a great tool. It was developed around 1990, I believe. Where did I say? Well, score, yeah, 1995. Yeah. So, so the clinical symptoms of DVT, leg swelling, pain with palpation, gets a 3. Other diagnosis less likely than pulmonary embolism gets a 3. Heart rate greater than 100 gets 1.5. Immobilization greater than 3 days or surgery in the previous 4 weeks gets 1.5. Previous DVT-PE 1.5. Hemoptysis 1. Malignancy 1. So there is a mnemonic. I think the students will be happy to see a mnemonic. I learned this only when I was preparing for this presentation. Don't die. Tell the team to calculate criteria. So don't is DVT symptoms, die, diagnosis most likely P, tell is tachycardia, the team is the 3 days and 30 days. 2 is thromboembolism in the past. Calculate is coughing or blood. Criteria is cancer. So I thought that was pretty cool. Um, so I am not going to remember that. I know for a fact. So I probably will be carrying this in a pocket anyways. Um, so high is if it's greater than 6, moderate 2 to 6, and low less than 2. So this is a clinical probability score before when a patient comes in and um, you want to rule out pulmonary embolism or diagnose pulmonary embolism. Why is it important? Because when a patient comes in with this criteria, okay, let's go back here again. So 2 criteria, less than 2. So if anybody comes with chest pain, everything is normal here. They may just have, what do we have here? Hemoptysis, okay? So that gives a Wells criteria of 1, right? Or maybe they just got recently diagnosed with lung cancer. So we can have one of those. So here, Wells score is less than 2. Can pulmonary embolism rule out criteria? That is called PERC. So all the 8 criteria here: age less than 50, heart rate less than 100, oxyhemoglobin saturation greater than or equal to 95, no hemoptysis, no estrogen use, no prior DVT or PE, no unilateral leg swelling, no surgery or trauma within the past 4 weeks. Then if all these criteria are fulfilled, then you are pretty much excluding pulmonary embolism. Okay, you could not exclude any of those. Okay, then then you are going to next level, D dimer. So I would say, like, when you are talking about Wells score, like a lot of these criteria that they are saying here is included in Wells score. So pretty much like when you have a low Wells score, you go to measure the D dimer level. And if the D dimer level is low, no further testing required. So you're pretty much like safe. Low probability for PE with Wells score, low D dimer, no PE testing needed. If it is greater, then can you do a CT angio? Is it possible? Then yes, go ahead and do it. If it's not possible, let's say the patient is extremely obese, will not fit in the CT scanner, patient cannot lie flat, he has a kidney damage, who cannot get an angio, then do a VQ scan. So angio is done. Angio is positive, then PE of course is diagnosed. Angio is negative, PE is excluded here. And inconclusive, then go for VQ scan. If the VQ scan is normal or low probability, then PE is excluded. Mostly, for the most part, I'm not going to go into those gray areas now, and I don't think we need to go there. We will run out of time. If VQ scan is negative, then no further testing is warranted. So here you see the importance of D dimer here. We are coming with a Wells score, low Wells score, and the determination to do a CT angio is done by D dimer level. Okay, so that's where it is important. If it is low, then you don't even have to go further. So intermediate probability, let's say the score is between 2 and 6. So a patient presents with sinus tach, which is what, 1.5, had a surgery like 4 weeks ago, had a cholecystectomy, 1.5. So we are already in 3 now. Then what do? You are doing a D dimer, okay? D dimer low, then pulmonary embolism likely excluded. Again, like D dimer, see, in low and intermediate, D dimer levels are so important. When it's low, you're essentially excluding, subjecting the patient to a CT angio. So then if you can do it, if it is positive, then go for a CT angio. High probability, If the well score is greater than 6, you don't have to go for D-dimer, just go for CT angio, okay? So what is CT pulmonary angiography? It revolutionized. In the past, it was a traditional invasive pulmonary angiography. I think CT pulmonary PA came around the late 90s as well, I don't, if I remember right. It has definitely revolutionized medicine in terms of management of PE. A positive PE, CTPA shows a filling defect, confirms the diagnosis of PE. Negative means likelihood of PE is low. Peripheral, very small PEs can be missed. And I have a story to share. So patient comes in, she was a female. She had come into the ER like 3 or 4 weeks prior. She had vague complaints, which sounded to me as pleuritic pain. Um, I think it was right or left, I don't remember. Then she got discharged. She had a CT angio. She got discharged, comes back with similar complaints. She had some changes in her chest x-ray. So they called me to admit as a pneumonia. So based on her complaints, and the pneumonia pattern, it didn't look right to me. So I went and checked her CT angio from before. That was done like within the last 3 weeks, and I saw, to my untrained eyes, I thought I saw filling defects, and I went to the radiologist and asked her. Sure, it was missed. It was not read by radiologists. So when in doubt, when the patient's complaints strongly is suspicious for a PE, go and look yourself. So CT angio is relatively contraindicated with renal insufficiency and iodinated contrast allergy. So here we have a protocol. All the radiology departments have protocol to do like Solumedrol, which is steroid and stuff like that. And for renal insufficiency, they admit 1 day prior and hydrate them. And then, or if they are how can you wait? Yeah. So if you want to hydrate and then get a CT angio within 24 hours, if you have the facility, then you can do it. So VQ scan, again, VQ scan is not used that much nowadays. It used to be in fashion before the advent of CTPA. But the key about VQ scan is if it is low probability, then no further testing is necessary. That was the conclusion that we arrived at with the PIOPED study that came in early 1990s. Then nowadays, like we are also like we are combining it with well score. So low probability VQ scan, low clinical probability, no further testing necessary. High probability VQ scan, high clinical probability, that is well score greater than 6, then immediate treatment is indicated. You don't have to do any testing. If it is intermediate, inconclusive, then you go for, if it is possible to do a CT angio, then go for it. So VQ scan, as the arrow shows, there is perfusion defect. And the CT angio shows on the right side, the perfusion, if it's white, that means it's patent. It's gray in color, that's a defect. It's a thrombus. So more thrombus as indicated by the arrows in the CT. So there are other alternative modalities. Let me see how we are going with the time. I don't want to go into details, but if you are in a place where you cannot get CT angio, you can combine with a lower extremity ultrasound with Dopplers and an echocardiogram. So this is a pulmonary angio, invasive pulmonary angiogram, and it shows there is no filling going on here. So that's indicative of PE. So we are not going for invasive pulmonary angiogram these days. If you are looking to thrombolize locally, um, if you're combining treatment, then you can go for it. Otherwise, we are moving away from it. So treatment. Okay, this is a busy slide. Treatment is basically based on hemodynamics. If the patient is hemodynamically unstable, then you start, like, go admit them to ICU, do fluid resuscitation and so forth, and then start treatment. That's the cascade there. The other one, the stable. So if it's stable, then you can probably safely admit on a monitored bed and then start anticoagulation. So that's how you categorize, like, your treatment is dependent on how stable the patient is. So do resuscitation if they're hypotensive. Be careful with your IV fluids. Don't do a lot. The hypotension is because of right ventricular failure. So you don't want to give too much fluid and then cause fluid overload. Be cautious with your fluids. You can start with inotropic support. You can, the preferable agent is norepinephrine. Um, if they have arrhythmias, then you know take care of those first. Then those patients automatically qualify for thrombolysis. They go for TPA. If thrombolysis is not successful, then you go for embolectomy, either surgical or catheter directed. And catheter director, I just put out those things. You don't need to know all of those fancy things. The most common ones that we use is TPA. Surgical embolectomy is not available in all centers. In in large centers, you have surgical embolectomy option available. For stable PEs, and we talked about unstable and stable in the first slide, in one of the first few slides. So I'm not going to go back there. So stable ones may have right ventricular strain or may not have right ventricular strain. So both of them start with anticoagulation, and all these are the choices we have now: unfractionated heparin, low molecular weight heparin, direct factor 10A, and thrombin inhibitors. Fondaparinux is like a synthetic indirect factor 10A inhibitor, and vitamin K antagonist, sorry. So warfarin is not started initially because it takes few days to act. So you start heparin or any other thing, and then you switch to warfarin. Okay, so this is a busy slide. My attending will be mad at me if he sees this one. He hates when I just copy the picture. He likes me to draw it all. I didn't have time to do that. So anyway, it's a busy slide. I don't know how much you can see, but what it says is, like, if there is whatever we talked about, like if hemodynamically stable patient, if anticoagulation is indicated, then go for don't wait. Like if they are going to have radiological testing like CT angio, greater than, if it's going to be greater than 4 hours, go ahead and start anticoagulation if they don't have any risk of bleeding. If the diagnostic evaluation is going to be less than 4 hours, then wait until get the testing done, confirm, and then start the anticoagulation. Um, so if the patient is confirmed with a CT angio and they have high risk of bleeding, like surgery, malignancy in recent intracranial hemorrhage, or malignancy in spine and stuff like that, then you can't obviously anticoagulate them. So you can consider doing an IVC filter. Okay, so let's say your clinical suspicion is low and the diagnostic evaluation is going to be taking longer than 24 hours. Then start on anticoagulation if they can. Okay, so well, if diagnostic evaluation is going to take longer than 24 hours, And if they don't have bleeding risk, you can start anticoagulation. But if the diagnostic evaluation is going to take less than 24 hours and you can wait, then don't start anticoagulation. Am I making sense? Are you guys with me? Okay, I'm taking it as a yes, or everybody's
Yeah,
speaking.
one has answered yes. So
Okay. All right, so we are going to hemodynamically unstable ones here. So hemodynamically unstable resuscitation, they are still unstable. And you see evidence of RV overload. Is thromboembolic therapy contraindicated? No? Then go ahead and start thrombolysis. If yes, then go for surgical or catheter directed embolectomy. Okay. So, and then when there is a clinical improvement, you can go ahead and continue with anticoagulation. If there is no clinical improvement, then go for repeat systemic thrombolysis or catheter directed thrombolysis or surgical embolectomy. Okay. So for those hemodynamically stable, then we already talked about, hemodynamically stable patients, right? So when they are, so let's go to the other cascade. Where are we now? So we talked about evidence of RV overload, right? So there is no RV overload, hemodynamically unstable, then you are looking for some other causes of hemodynamic instability. So it's not from PE. Okay. So these algorithms are basically helpful when you are waiting to diagnose. So whether to wait or not wait is where is the question. So if you in a stable patient, if you have a high suspicion of PE, and if you can wait, I mean, if you diagnosis is going to be less than 4 hours, you wait. If not, go ahead and start anticoagulation, provided there is no contraindication. So that's what I'm trying to get important, and that's the message I want to get. Okay. Severity index score. So this, I just put it out here. This is just to assess the prognosis of the patient. Okay, so I don't want to go in there in detail. So what are the treatment like doses that we have? Unfractionated heparin. The goal, we have like weight-based and fixed dose protocol. Each institution has its own protocol. Your goal of APTT should be 1.5 to 2.5 times the control. Low molecular weight heparin. Oh, this is when it came, I was so excited, but it costs, I don't know, Maithili, you may be able to tell me. It used to cost $1 per milligram, right? I do not know if it's the same
yes,
now.
it was very expensive, and even now it is expensive.
Right.
We are not
Ridiculously
uh,
expensive.
favoring that, anyways.
Yeah, in outpatient setting, but it really changed the way we managed PE. I remember the hassle of having the IV heparin and having to do the CBC and PT every 6 hours. We still have to do it at times, but then this is like once or twice a day injections. And this has changed. You can use it in pregnancy too. So that's a great one. Tinzaparin is not available in the US. Um, so fondaparinux, it's a synthetic indirect factor 10A inhibitor. It's an alternative to low molecular weight heparin. It's an acceptable anticoagulant for most non-pregnant patients, but especially when patients have history of heparin-induced thrombocytopenia. So that's where this plays a role. And I have got this dose here, like 5 milligram once daily, 7.5. Okay, I'm not going to read out that. So it's not used as a first line agent because it has no reversible agent like enoxaparin and heparin. They all have reversible agent if they start bleeding. But whereas this one doesn't have. So it's not a first line agent. Direct factor 10A and thrombin inhibitors, rivaroxaban, which is also known as Xarelto. First, you start as a 15 milligram twice daily, and then you change it to once a day dose after 21 days. Apixaban start as 10 milligram twice a daily, and then you change it to 5 milligram dose after 7 days. Edoxaban, I don't have any familiarity with that. I don't think it's available here. I don't know. So other two, edoxaban and dabigatran, they all need first few days of heparin, and then you switch it. So this is another busy slide. This is just to calculate on a bleeding score, like what are the risk factors: age, previous bleeding, cancer, metastatic cancer, renal failure, thrombocytopenia, liver failure, previous stroke, anemia, antiplatelet therapy, recent surgery, alcohol abuse. All those things are risk factors, and there's a score. I'm not going to go into the details. So selection basically depends on selection of the agent. I have a bias. I have personal preference for apixaban, Eliquis. I feel that there is a less risk of bleeding. And there is a study that it has a less risk of bleeding. So I prefer that. If once a day dose is preferred, if you are questioning non-compliance with the patient, then go for the others like Xarelto, which is rivaroxaban. So choice. So as I said, the newer treatments have revolutionized the way we treat. We are not admitting all the patients. If you have patients that fit all these criteria, like if they are ambulatory, if they have good support at home, they have low risk of bleeding, no renal insufficiency, then you can go ahead safely and discharge them from the from the ER and manage this as outpatient. Start like Eliquis or low molecular weight heparin or rivaroxaban, anything that you like. Duration of therapy, minimum of 3 months, sometimes 3 to 6 months. Some patients who need like indefinite anticoagulation, that's something that you have to go with on case by case basis. And I hope those cases are, what are those? Like, if they have like hypercoagulability that cannot be removed, if they have recurrent PE unexplained, then you have to, obesity, like extreme obesity. Those are the patients that, cannot go off anticoagulation. Sometimes they have to be on it lifelong. Prognostic factors we discussed earlier, presentation, like right ventricular strain, hypotension, EKG abnormalities, ABG abnormalities, troponin, BNP, all these are, bad prognostic indicators. Okay, word about anticoagulation in COVID, and this is always a changing topic. What I read in April is not same now. Like there was a lot of discussion about D-dimer and basing our judgment based on D-dimer. Now, most recent ASH, American Society of Hematology guidelines as of October says that if you have low or intermediate probability of PE, even with COVID, you can go for low dose enoxaparin. So critically ill, in the past, in like a few months ago, they based it on D-dimer level. But now they are going with just a clinical probability, and they are saying low dose enoxaparin is sufficient. Intermediate dose, some institutions are still using it if the D-dimer is greater than 6 times normal in critically ill. If it's that dose is 0.5 milligram per kilogram every 12 hours, that's enoxaparin again, or unfractionated heparin 7,500 units every 8 hours. Acutely ill who are in the hospital but not critically ill, you just use low dose enoxaparin. So outpatient anticoagulation. So that was interesting for me. Like, there are a lot of patients that we are asking them to stay at home and doing home quarantine, and we are not testing D-dimer or anything like that. But do you recommend anticoagulation? A lot of my doctor friends say, like, oh, start taking aspirin, low dose. I do not know. I mean, if we have any role to for aspirin or not. If I get COVID and if I get very sick, then I may consider aspirin, but that has no scientific evidence. There's no base for that. People, because it's available over the counter, people are taking it. But if they have risk factors like that we discussed before, like obesity, cancer, immobility, surgery, pregnancy, but of course pregnancy you can't use rivaroxaban, like hormonal use. So any of those risk factors present for hypercoagulability in addition to COVID, then the authors of Up to Date recommend rivaroxaban 10 milligram daily for 31 to 39 days. Okay, with that, I conclude. Okay, we didn't go over.
Yeah. No, thank you. Thank you so much for doing this, Poornema. But it was a very comprehensive outlook and perspective on PE. I mean, it's a refresher to me. It was great to listen to those age-old terms of CT angio and stuff like that. But I had a
Right.
quick question. So
Sure.
in the COVID era, when you say in the US and India, it differs. So COVID, when you say COVID, you're talking about the COVID positive, definitely PCR positive patients here are designated as COVID positive, right?
Correct.
Those are the patients that you're talking about, the D-dimer being positive and then deemed COVID positive, or PE is a high probability on their differential diagnosis, and then they recommend the anticoagulation, right?
Right. So, correct. So what it is like, if there is a high, if you are able to do CT angio, I mean, of course, if the patient is in critical care unit, they are there because of severe hypoxia, right? Um, so if you had a chance to do CT angio, then you have a way to diagnose. Then you are going to do therapeutic anticoagulation. But let's say they are there and there's no way you can do a CT angio, then you just have to, and you have no reason to have a high suspicion for PE, and you have other reasons just from based on what you see in their lung imaging, then you can safely do either low dose. The current recommendation is low dose, but no one will fault you if you did intermediate dose, the 0.5 milligram per kilogram. The
But
only time,
essentially,
the
go
only
ahead.
time, what, go ahead. Sorry.
No, go ahead. Go ahead.
The only time they are saying is like if there's sudden decline in oxygenation, like, unexplained hypoxia, you can't base on just clinical imaging. Or if the catheters, like the intravascular catheters, start clotting, like if they are on dialysis, then it starts clotting, then you go ahead and do therapeutic anticoagulation without doing a diagnostic imaging. So without a clinically proven clot, they are recommending typically not to do a therapeutic anticoagulation, is what I'm trying to say.
Okay, so that is the clinically proven clot, meaning in a COVID positive, PCR positive person, clinically proven clot, meaning either by VQ scan or by CTA, right?
Right. Yes.
Okay. So because in India, in Chennai at least,
Mm-hmm.
the CORAT score, I don't know if you know about it,
Yeah.
the CORAT score on the chest CT regulates them, designating them as COVID or not. So their way is PCR positivity is not very much reliable. They just give about 70% of the time they're positive. So they very much do it based off of their CORAT scores on chest CT, which could be, the images could be from A to B to Z. So it's a little different there, even though the D-dimer is positive. unless and until I'm not so
Are-
sure whether PE comes under the highest diagnostic differentials there.
Yeah, so that's what I don't know if they are doing like D dimer based on the D dimer and the corads. Are they giving therapeutic anticoagulation?
No, they do not. That's what I'm trying to say, because
Okay.
PE has not been in their highest diagnostic when there is a positive D dimer and a chest CT corad score of 5 or 6, and that is infiltrates all zones of the lungs, and their PCR is negative. Despite the PCR being negative, the antibody being negative, the chest CT, if it gets a corad score of 5 or 6, you are deemed COVID positive. But
Yeah.
if your D dimer is still high and your CRP is still high, you're not given the diagnosis of PE, and you're not given the anticoagulation based off of PE. That's what I'm trying to say. I mean, anyone can correct me if I'm wrong, but that's the observation that I heard. And I mean, I discussed it with a few of them, and that's the way they move.
Yeah,
A
yeah.
little
No,
different there.
that's what they are doing here too. Like they are not giving any therapeutic anticoagulation. They may give, like the D dimer is like 3 or 4. They may give like 0.5 megs per kilogram, but they don't go for therapeutic anticoagulation even in
Okay. Anyway, thank you very much.
Oh, you're
It
welcome.
was great.
So I guess
Okay.
we'll end it. Thanks all
Yes.
for being here.
Thank you.
Have a good weekend. Take care.
Take care. Bye bye.
Bye.